So that was an awesome discussion on lateral ankle instability, and clearly that is predominates when you think of ankle instability. Certainly, one of the things that that you have to be clear about is that you're not dealing with high ankle sprains or syndesmotic instability. Far less common than lateral ankle instability, but clearly something that needs to be illustrated either with your certainly defining the mechanism of the injury. You know, a lateral ankle sprain is I don't know if opposite's the right word, but it's opposite the mechanism to create syndesmotic instability.
Agreed.
And with that, you know, usually patients have medial ankle tenderness or medial ankle instability when you're talking about high ankle sprains, right? So let's pivot a little bit and let's talk about medial ankle problems, medial ankle instability, medial ankle deltoid ligament tears and reconstructions, and we see this in by majority two different areas, right? We see it acutely with ankle external rotation, rotational type of ankle fractures. And we also see it in the advanced adult acquired flat foot, right?
Two different beasts.
Two different beasts. One is we're talking about acute in the ankle fractures, and more from a chronic attrition, deterioration, chronic ruptures of the deltoid in the adult acquired flat foot, the stage this stage 4, right? So let's start by talking acutely. So huge controversy as far as
I don't think it's that controversial.
Well, I think that you're wrong that it's not controversial. I think that there's lots of people out there that don't fix the deltoid whenever there is clearly a deltoid tear, i.e. the medial ankle injury lesion is ligamentous and not the medial malleolar fracture. Although there are some medial malleolar fractures, anterior collicular fractures that also have deep deltoid ligament ruptures too. But regardless, we're talking about external rotation ankle fracture, blown syndesmosis, blown medial ankle where the talus is separated from the medial malleolus by 10 or more centimeters. Deltoid, both superficial and deep, are blown. You fixing those?
I am, and you know, I think we've had this discussion before. I'm an advocate for fixing it. Why is the medial ankle ligament complex any less important than the lateral? We just spent the last half hour talking about, you know, why we need to repair the lateral ankle. The deltoid, the deep deltoid, it's the strongest ligament in the ankle complex.
Right.
It's twice as strong as the syndesmosis. We have all this attention toward the syndesmosis, and the deltoid rupture precedes that syndesmotic rupture. That's my position. Now, many will say, well, if you fix the deltoid, or if you fix the syndesmosis, the deltoid is superfluous.
What do you say to those people?
I would say I would disagree.
Okay.
Because I think that there's still a valgus thrust that can be created with lack of repair of the deltoid. I can't say that there's been a deltoid ligament that I've repaired and I wish that I had not repaired it. I can say the contrary.
Okay. So you've had some that you knew the deltoid back before this deltoid ligament reconstruction became a thing. Because before, I think we wouldn't do anything with it because we probably didn't have technology or instrumentation to even address it, right?
Or we just
because you're not going to go in. I mean, the deep deltoid is what, 4, 5, 6 millimeters in length. So you're not going to go in there, throw sutures in this just completely disrupted little teeny tiny broad ligament and think that you're doing anything for it. So,
and I would say the people that say that they suture the ligament back together, they may be, but they're only suturing the superficial deltoid,
right,
which has no mechanical integrity to the ankle mortise.
Minimal
to negligible.
Compared to the deep deltoid when you're talking about medial ankle stabilization or medial ankle instability, right?
Correct. I would call that more of a deltoid sprain.
So what complications or what post ORIF sequela were you seeing whenever you weren't fixing the medial ankle in blown, like completely blown out deltoids, superficial and deep, in these ankle fracture dislocations?
Yeah, I think we've all had the chance to go in and do a scope on people that have had a variety of ankle injuries, right? Whether it's unilateral, bimal, trimal, syndesmotic disruption, and you'd see a lot of that lateral chondromalacia.
Yeah.
And that's even with the syndesmosis fixed.
Yeah.
And my position on that is there's not lateral transverse plane deviation of the talus because you fix the fibula, you fix the syndesmosis. But there's valgus kick, there's valgus thrust, and that lateral part of the talus impacts the lateral tibial plafond. And my position is it's because the deltoid is incompetent.
Yes.
And that's what I would see, and that's what I surmise is the problem with these people that I'd go back in and scope.
Do you think some of the people who have a concomitant flat foot are at greater risk, and maybe those were the ones because of the valgus thrust, because of the structure of their foot, may have played a role in that?
It could be, and again, then I think we're talking about maybe two patient populations.
No. I'm talking about an acute ankle, a rotational ankle injury that the deltoids were blown. That also, when you fix them, also have a flat foot, and when you did not reconstruct in your younger years, when you actually had hair, when you
Your eyebrows were distracting me.
I'm sorry. I waxed them before I came. And before that, if like for me, I would see some of the ones that actually have a concomitant flat foot. They have this horrible rotational ankle fracture dislocation where the deltoids are blown, and then you fix them. Then I see that the talus tilts a little bit more in valgus, because a lot of them that when the deltoid is torn, I think a lot of them still do well. I think the more minor ones that maybe don't dislocate, I think they still do okay, do probably just as good whenever I don't do my medial ankle reconstruction or my medial, so unfortunately I have to say that I agree with you, but I do agree with you that I'm also probably more aggressive or more in the camp of a medial ankle stabilization is what we're typically doing in the acutely ruptured deep deltoid.
So in those patients that have an obvious bimal equivalent, you can drive a truck through the medial gutter. Are there any of those patients you don't fix the deltoid, and if so, why?
Currently, no.
Okay.
Currently, no. I look at that and I go, I know those medial ankle ligament structures are gone. And to your point, I mean, why should the deltoid ligament be thought of any differently than syndesmosis or lateral ankle instability? I mean, lateral ankle ligaments are reconstructed because of symptomatology.
And it's also chronic.
A chronic thing, yeah. Right. So we are talking about something obviously a bit different. I mean, and there's literature that's come out of Duke, and there's some literature that's been published in Journal of Orthopedic Trauma about this exact same this condition, on whether or not you fix them or when you don't. I think I'm convinced that I think they do better, whenever you fix them, in the ones that are completely blown. Where I'm a little bit on the fence is, it's not quite the dislocation or medial clear space that you see on the initial injury, but you're sure that the deltoid is torn.
So
you're super aggressive. You're doing all of them.
If I know that deep deltoid is ruptured either by way of preoperative imaging or intra-op stress evaluation, I'm fixing it.
How do you intraoperatively stress them?
So I'll just kind of a shuck test. So I'll grab the tibia, I'll pull the foot laterally, and then if there's something that's pathologic greater than 5 millimeters, that's one that I'm fixing.
How about valgus? Did you check the valgus tilt as well?
So I will. So it's the same maneuver. So it's just like a lateral ankle, right? So I'm doing a talar tilt, but I'm also doing a kind of a talar shuck test.
Do you fix your syndesmosis before you fix your deltoid?
So good question.
So let's talk about sequence as far as when you do your medial ankle stabilization.
So whether syndesmosis is involved or not, I will put anchors. I do two arms. So I'll put one anchor into the talar body neck region. I'll put one into sustentaculum tali. And whether I'm using suture or tape, I pull those out, I hemostat those. Then I'll go and I'll fix my fibula and or my syndesmosis and or my posterior malleolus.
So you start immediately with placement of your anchors, and why do you do that? As opposed to, I would think the algorithm, and for me I struggle with this because I'm similar, is that the algorithm should be fix the fibula, fix the syndesmosis, or fix the fibula if that clearly that's broken. Make sure it's out the length so that it can hold the talus within the mortise. Check syndesmosis. If it's unstable, reduce it, stabilize it with whatever fixation that you choose, and then after you do that, then check the ankle for a valgus instability, and if it's unstable, then do your medial ankle stabilization. So you're like, I'm doing this. I'm fixing medial side, and it's easier for you to place them in the medial talus.
I already know about my medial instability before I fix fibula and syndesmosis.
Gotcha.
I've already checked that box.
Gotcha.
And the reason I do at least put the anchors in first is if I fix my fibula and syndesmosis, it closes that medial gutter down so much, it's difficult to get that talar anchor in.
Gotcha.
Now some would say, well then if it closes down with your fibula reduction and your syndesmotic reduction, then why fix it? Going back to your earlier question, because I think there's still a valgus thrust to that needs to be addressed. So I'll put my anchors in talar neck body area, sustentaculum tali, bring those sutures out, snap them, fix everything else, come back, and then I'll put another anchor with each arm of that suture into my medial mal.
Okay.
And I'll tension that until I have no valgus thrust.
Gotcha. That's great. That's great. That's awesome pearls. So let's just talk about your anchors that you're using. Elucidate on that a little bit. Just tell me which anchors you're using and the size, and maybe even go through the actual. Do you have to tap these? You clearly drill a hole.
So drill, and I'll do Citrafix anchors. I'll do a 3.5 in the talar neck body.
Okay.
I'll do a 2.9 in the sustentaculum tali. And I tend to use tape, so 1.1, 1.3 tape.
Okay.
And then I'll take one arm of that suture, each of those sutures, or tape, and then I'll put it into a 3.5 Citrafix anchor into my medial mal.
Okay.
And then tension it.
When you say medial mal, the direction of that is going sort of like in the direction where your medial mal screws are if there was a medial malleolar fracture?
Exactly right. So you're not blowing out the medial side, you're not going into the gutter.
Gotcha.
Yep.
Okay. Yeah, that's awesome. And have you had any complications related to it? Have you over tightened it, or?
I have over tightened it. And in the past, when I first started doing this, I'd use peak anchors. Mm-hmm. So I did overcook a few, had to go back in, cut the suture, or remove the anchor.
Gotcha.
And I think the best position I find is probably about 10 degrees of plantar flexion, probably about neutral to maybe a little bit of inversion, because it is easy to over tighten the medial ankle. I think it's easier to overcook, over tighten the medial ankle than it is the lateral ankle.
Gotcha. Gotcha.
And I know you've seen the light.
Yes.
You're doing deltoid repairs now.
Seen the light.
What's your construct?
So my construct, and I do it. I don't know that I do it in ones that are more subtle, because I mean there were ankle fractures that had deltoid ligament injuries over the years that you've done, I've done, that everybody has done, that the deltoid ligament heals. And whether it's because those were casted for a longer period of time and you've allowed that ligamentous healing to take place, I'm not 100% sure. But clearly ligaments, acute ligament ruptures, heal on their own, right? You don't have to do it on everybody. So I think that's what makes it a bit controversial. You're not fixing lateral ankle injuries. You're not going in and acutely fixing the lateral collateral ligaments when somebody sprains their ankle and tears those ligaments. And I completely understand why, and I've seen some that have failed in valgus and have developed post valgus positioning of their ankle, and I think that I can attribute it to the deltoid rupture. My reconstruction is a little different. I start medially, just like you do, because it's easier to laterally translate the talus whenever the fibula isn't fixed and the syndesmosis isn't stabilized. So I laterally translate it. There's all this hematoma in the gutter, and I push the talus laterally so that I can see where the deep deltoid ligament is. It's usually directly below that comma-shaped facet on the medial side of the talus. And I make a drill hole almost in the exact location of that deep deltoid, and I'll drill into the talus. And then I'll use Stryker's Alpha Vent, which is I have to tap the talus too, and I'm below the dome enough, but you have to tap it because it's pretty hard bone, and I screw it in. And there are 2 sutures, 4 strands, that come out of the Alpha Vent, a blue and a white one and a blue and a white one. And what I do is I make a drill hole in the medial malleolus. And I'll take a 2.5 drill bit and I'll start it in the anterior colliculus region, and I'll make a drill hole from outside into the medial gutter on both the anterior colliculus and the posterior colliculus. And I'll pull a blue and a white strand through the anterior drill hole and a blue and a white strand through the posterior drill hole. I'll stat them, and then I'll go do my lateral. I'll do my fibula fracture, assess the syndesmosis, directly assess the syndesmosis, and then if it's unstable, then I'll reduce, stabilize with whatever soft tissue or screw fixation, and then I'll come back medially. And now I'm ready to do my deltoid reconstruction. I usually put the ankle in about neutral position, maybe a little bit of plantar flexion, as you said. And I have one of the residents pull the white strands, because that's now attached to the medial talus, and that pulls the talus, make sure that it's medial enough, and then I'll tie the blue strands or the blue sutures over top of the bone island between the drill holes. Once that's done, then I'll take the white ones and I'll tie the white ones, so I have two knots there, and then I'll go a little farther up the tibia, in the distal tibial metaphysis, and I'll put in a omega anchor, which is which I use for my second row for my medial ankle stabilization. And it's really not it's not a deltoid ligament repair. It's more of a medial ankle reconstruction or medial ankle stabilization in these acutely injured.
So you made a good comment, interesting comment about trying to equate for the naysayers that they say deltoid repair shouldn't be done because you don't do it on acute lateral ankle sprains.
Sure.
So what if you had obvious complete disruption of your lateral ankle complex and a fibular fracture? Do you think that those naysayers would change their opinion on fixing the fibula and doing a lateral ankle reconstruction of those ligaments at the same time?
That's an excellent question, and they probably would if that kind of injury happened or existed. That while you're there, going in and reconstructing or stabilizing those ligaments would make sense. I think this remains a controversial topic. I think that there will be literature that comes out that helps us in a couple different areas. Number one, the technique, as far as we're kind of doing what we think is right and sort of developing our own technique, which is part of the evolution of surgery. So the technique and indications, which ones to do it on, I think will come out with time. And having side by side ankle fractures that they do and they don't fix the deltoid will clearly, and there are some early studies that are out there that shows that stabilizing the medial ankle in certain ones does make a difference. But I think more studies, more research to be able to answer some of these questions, and hopefully, this won't be as controversial, 3, 5, 10 years from now.
Any complications with your deltoid repairs?
Ironically, the only complications I've had have been, I had an elderly lady, and she was diabetic and she was neuropathic, and I did this on her. Again, because I wanted to stabilize all parts of the injury given her neuropathy and things like that. And she had no issues with the placement of the soft tissue anchors and everything, but what she did, she had problems with the suture over the medial malleolus. It's the only one that was sort of rubbing and created almost like a foreign body granuloma over the area. And I don't know what was different about the technique, or maybe the quality of the bone because of her age may have made a difference, and that it was like shifting, it was almost cutting through the bone a little bit as the ankle was moving up and down. But I took her back to the operating room, made an incision through that area. I basically cleaned up all of the suture knots and the suture that were over there. And I mean, within, the postoperative course for that was completely uneventful. Some of her sort of underlying pain, probably because of that granuloma, and you'll see that from suture knots and non-absorbable sutures, especially in areas that are fairly superficial, like the medial ankle is. You'll see that occasionally, but as soon as I sort of took care of that, she was doing fine. And it was far enough down the road where I felt comfortable that the medial ankle was stable enough and it healed. And when I took her into the operating room to clean out the the medial ankle. I even stressed her ankle in a valgus stress, and it was fine.
So obviously acute deltoid repair is controversial. Chronic, not so much.
Not so much. You have to balance the foot underneath the ankle. And if there's any hint of less than neutral position and stabilization of the foot under the ankle, I think the deltoid ligament, no matter what you use, it's not going to hold up.
It can be done in isolation.
Exactly,
right?
exactly. But not only can it be done in isolation, but you got to make sure that your reconstruction of that foot and stabilization of the flat foot underneath the ankle is no longer putting significant or any any significant strain on your deltoid reconstruction.
Right.
Because it may look great on the OR table, and I've done that where I'll fix my flat foot and I'll think it's spot on. And I'll either leave my medial column unstable or whatever, but there's still enough valgus thrust that's going through that one or two cycles on the Grossman instron intraoperatively is nothing compared to a million cycles with them walking.
And that's a pretty weak scale.
It is a very weak scale, yeah. Thank you.
Yeah.
Comparatively. So but I've been lifting, so I mean I'm trying to get that. But my point is intraoperatively testing it with one or two sort of valgus thrust on your deltoid reconstruction isn't really commensurate with whenever the patient starts walking. And the other thing that I think is important with whenever you're talking about these chronic deltoids is that you have to evaluate these patients their entire limb. Mm-hmm. So a lot of times the valgus thrust, your foot is spot on perfect, but you fail to evaluate the patient with them standing and see that they have like 25 to 30 degrees of genuvalgum, that you're never going to be able to balance the foot to the leg until the knee or until that lower extremity is reconstructed. Your deltoid ligament is going to fail within a few weeks of them walking on it if the lower extremity is still in a horrible valgus position.
We talked about order of repair previously. Talk about your order of repair in the stage 4 flat foot. What are you doing? When do you repair the deltoid? Is it first? Is it last?
I'll place my anchors first, and I'll get everything aligned and or opened, put in my semitendinosus, and usually I have one going from usually the talus to also up to the tibia, as well as to your point, from the subsentaculum. So it's like a forked semi-T, and that's what I use to sort of pull my entire, because now, the majority of these you're doing a subtalar fusion on. So the vast majority of them, the talus calcaneus is now one bony unit. So I'm using ligament, again, medial talus, ligament, or an anchor into the subsentaculum tali, and then I'm using that arm to pull it all the way up.
Are you securing it to the tibia with a endo button, a screw?
Or interference screw.
Yep.
And I tighten it. The other thing that I'll sometimes do for additional repair is that if I have a diseased, or if I have a posterior tibial tendon that I can sacrifice, and the majority of the time I can because I'm doing hindfoot fusions with these, I'll cut it proximally, and then I'll use that from the navicular to the anterior medial tibia, almost like my superficial ligament bundle of my tibio-navicular. So I got talotibial, I got calcaneal tibial, and I have, from use of my posterior tibial tendon, I'll have navicular tibial to try to reconstruct my entire medial ankle ligament complex.
That's a solid repair.
How about you?
I haven't found anything that predictably works, but I'll do a semi-T graft. I do a double bundle. I'll put the same arms just like you do, subsentaculum, but I'll run it through the lateral side of the calcaneus.
I do the same.
Run it through the talus, and then I've tried bicep buttons on the front of the tibia. I've tried putting like a hanging screw underneath my looped semi-T graft.
Yeah.
All are moderately successful,
Yeah.
because I think just the amount of shear and strain that goes through that side of the ankle, even in a balanced hindfoot,
Yeah.
it's difficult to keep that ankle away from a valgus kick.
Yeah, I agree. And I think all things being balanced, I think those are the ones, if you're able to get the foot stable and neutral not only the hind foot, but the medial column, get your columnar alignment reduced and stabilized. Take care of the equinus contracture if there is any posterior muscle group lengthening. I think the ones that I have been successful on, which unfortunately probably isn't even the majority, is because I've been able to achieve a balanced, stable foot under such that the strain on the deltoid, my deltoid reconstruction, is fairly physiologic. You know, it's not anything significant. I just lost my train of thought.
Is there, and this may be an unfair question, is there a certain amount of valgus to that talus that you say, all right, I'm gonna give this a swing and try to reconstruct it? Or is there a certain amount that you say, you know what, I'm doing a TTC fusion or I'm doing an ankle fusion?
Yeah.
When do you make that call?
Yeah, for me, and this is what I was thinking. For me, it has everything to do with the status of the cartilage in the ankle. So I've had a couple where I've said, you know, screw it, I'm going to step up to the plate and take a swing and try to reconstruct this ankle as opposed to doing a TTC or anything like that. Mm-hmm. And I personally believe now that if the talus is in a valgus position for a long enough period of time, and you can either evaluate intraoperatively with a scope or intraoperatively with an arthrotomy, that all the cartilage, significant amount of cartilage along the lateral talar shoulder and along the lateral tibial plafon is gone. So there's this gutter of cartilage that's gone over the lateral distal tibia, and the lateral talar shoulder has significant chondromalacia or completely gone. I don't think that ankle is reconstructible unless you try to do any kind of osteochondral allografts to those areas. Mm-hmm. I think that once that talus wants to fall into that gutter, I don't think that it's. I think your opportunity is gone.
Do you do any purposeful, like lateral sleeve work where you try to cut through the lateral complex to give the talus a little bit of an ability to swing medial, or do you think it's
I haven't. Not needed? That's a good point. I haven't done that. Most of the ones that I've been successful in, and again, it's probably the majority like you, I think a lot of deltoid ligaments fail. I think I can get the ankle reduced. I can manually get that ankle so that it looks perfect. Mm-hmm. But again, the wear of and the adaptation to the lateral distal tibia and the lateral shoulder, I think plays a huge role in whether or not that talus wants to continue to fall into that valgus position and valgus alignment. And then therefore, regardless of your flat foot reconstruction, even if it's spot on perfect, I think that the ankle will still want to fall into that gutter. The talus still wants to fall there. Good. So which puts a ton of strain on your deep deltoid.